Welcome to the Determinants of Her Health podcast, where we will explore the systems that affect women's health and how we can shape them. I'm your host, Allie Felker, and I am so excited to be beginning this journey with you. Today is an introductory episode. I'm going to be taking you to school a little bit, and we'll be kind of setting the framework for how this podcast is going to go over the next couple of weeks. And I'll also be sharing my story, sharing with you my story of loss, my story of hope, and of why I care so very much about women's health care in America. So each week, we are going to be looking at a different topic related to women's health. And we're going to be looking at this through the lens of zooming into individualized stories, and then also zooming out and looking at the systems that are affecting these stories and making these things happen. We'll also be ending each episode with things you can do to advocate for yourself and also join the greater network of women who are advocating and working for real systemic change in this country. Before I dive into my story and explain kind of why I'm so interested in this topic, I want to bring up a framework that we are going to use for this entire journey. And this is the lens through which we can view every single one of these topics, whether this is something that is related to hormonal health, or this is something that is societal or a cultural shift. I want us all to be viewing these things through a lens of reproductive justice. The first time I heard the word reproductive justice and the first time this framework was explained to me, I'm not even kidding you, I got chills all over my whole body because it was like things suddenly clicked. And I just got this overwhelming, yes, absolutely. This is the way we need to be viewing so many topics in this country, and not just those that are related to women's health or reproductive health. So the reproductive justice framework is one that was created by Black activists and advocacy groups. You can find the full definition on the Sister Song website. It was created by activists including Loretta Ross, whom I'm currently reading one of her books, and she is just an inspiration when it comes to reproductive health care, reproductive justice, and really understanding these things outside of the lens of just the pro-choice and pro-life debate, but really seeing things in a broader picture. The reproductive justice framework is this. It is a human rights approach to these issues that declares that every person has the right to not have children, to have children, and to parent those children in safe and secure societies and communities. So let me repeat that. It is the human right to either decide not to have children, to make the decision to have children, and then to also parent those children in safe communities. And for me, this just totally clicked because when my first child was stillborn, I felt like something greater was happening than just this unexplained tragedy. I felt like something truly wrong had happened to me. And as we'll see when I explain my story a little bit more, this truly is a human rights issue. It truly is a justice issue. And not ironically, my child who was stillborn, his full name is Henry Justice Felker. And so when that clicked for me, and I sort of realized that so much in my life had been building to this framework of restoring justice and seeking justice, especially for women. It was just again, chills all over my body. So while we're going through these topics and we're exploring them together, we're going to be exploring them through the lens of reproductive justice and really seeing women's health as a human rights issue. We all have the human right to living healthy lives and to choosing whether or not we're going to bring children into this world, and then being able to parent those children in ways that are healthy and safe and sustainable. Okay, bear with me because we're going to go to school for a minute. Many of you are already familiar with the framework of the social determinants of health. But just to review, the social determinants of health are the non-medical environmental conditions where people are born, live, work, and age that significantly influence health outcomes, disparities, and quality of life. The social determinants of health include economic stability, they include education access and the quality of that education, they include access to healthcare and the quality of the healthcare that is accessible, neighborhood and built environments, that's whether or not you're able to walk outside your door and go for a walk and live in a healthy and safe community. And then social and community context. Do you have a support system? Do you have friendships? So all of those things coalesce to create the social determinants of health. And we also see that health outcomes directly correlate to income. And so when we're talking about all of these things, we're always going to be remembering that these social determinants of health are things that are significantly impacting health outcomes. And so especially when we talk about marginalized groups, we need to be remembering those social determinants of health and how each one of the topics that we talk about are impacted by that. Even though we're talking about things that are very, very broad, we can think about them all within the context of the social determinants of health. And that is actually where the name of this podcast comes from, because we are looking at the determinants of her health. What are the things that are determining the health outcomes for women in the United States? Finally, I want to add a note on inclusivity. I recognize that not everyone who has some of the biological traits of females is going to identify as being a woman. And while we use this encompassing term of women's health, I just want to say that anyone who does not find that to be an identifier for them, this podcast is still for you. You are welcome in this space. I also want to recognize that women's healthcare is something that has been consistently neglected in this country. It was only in the 90s that women were included into studies, that it was mandated that women had to be included in medical studies and medical research to see how certain medications and interventions affected female bodies. And so as much as I want you to hear that you are welcome here, that I will try to use inclusive language as much as possible, I also want to recognize that women have been erased, excluded, and that's something that's very important as well. And so we will be moving forward with the term women's health care, recognizing that not everyone who this applies to is going to identify as a woman. So I just want to state that inclusivity is very important to me, and I will try to use inclusive language. And also, it's important that we're not erasing half of the population because they have typically been erased and excluded from these conversations. Okay, let's all take a deep breath because I'm going to let you into one of the most precious parts of my life, and that is Henry Justice Felker, my first child, the boy who made me a mom. I have been pregnant 3 times, and I have 2 living children. My first child was stillborn, and I was just about 32 weeks pregnant the day that we lost him. And I share his story because there are so many points in which I can look at systemic failures that led to his death. And I can look at that objectively, and the very logical part of my brain says, these are the areas that if we fix them, more babies will come home. And that gives me a lot of hope, and it makes me really excited. And I think sometimes people will see me tell this story and wonder why I'm smiling and why I'm not moved to tears. This is something that A, I've processed for almost 6 years now, and B, I do see the glimmers of hope. I do see the opportunities for change. And while I was failed by a system that did not prioritize educating and empowering me as a new mom, I do believe that there are so many new moms that can be educated and empowered and bring home healthy living babies. And that makes me incredibly happy. Okay, so at the end of 2019, my husband and I were going to Disneyland, and I wore a pad while we were driving down to Disneyland because my period hadn't started yet. And I was like, it's my luck, it's going to start while we're driving. So we get down to Anaheim and it still doesn't start. And I have this little like, well, maybe I'm pregnant, but I think there's no way I'm pregnant. Like I just stopped using birth control. I was on an IUD. We get the pregnancy test and I take the test in an Albertsons bathroom. And I'm sitting there with the big long list of instructions and I see 2 lines and I'm in complete shock. And I open the bathroom door and my husband's standing there and I just like hand it to him like, does this say what I think it says? And we were like immediately overjoyed. I was in a state of shock. I was really scared to become a mom. And that was crazy. Fast forward March 2020, the whole world ends. Everybody goes into hiding. COVID is crazy. And I am now pregnant in a pandemic. And I don't really know how to compare this to not being pregnant in or being pregnant not in a pandemic, because this is my first pregnancy. I don't really know what to expect. Every time that I go in, I am told that I have a healthy, textbook, normal pregnancy. I'm 27 years old. I'm the perfect age to get pregnant. My body's doing great. And one thing that I remember very vividly was I was on the What to Expect app and I read something about kick counting. And so I asked my physician, should I be counting kicks? And she said, not yet. And then I think it was probably 28 weeks or so, she said, oh, you can start kick counting now. But with no education about what kick counting was, why it was important, what it looked like, nothing like that. I was told the standard, don't eat lunch meat, don't change a litter box, don't get your nails done, those sort of standard things that came to me in a packet once the pregnancy was confirmed. Around 31 weeks and 5 days, I noticed that Hank hadn't been moving. It was a Tuesday and I was like, I was, working all day Monday and I didn't feel him. And normally he's a mover. But I had also heard that, babies slow down near the end of pregnancy. And I thought, well, 31 weeks is a little early, but I guess I am in the 3rd trimester. So we're getting to the end. So he must be slowing down. Just a quick side note, that is false information. Babies do not slow down at the end of pregnancy. I called my doctor's office. I said, hey, I haven't really felt my baby move. What should I do? And the nurse informed me that I should do kick counts. No education about what that was. And then if he didn't move in an hour, that I should go, or if I didn't get 10 movements of it in an hour, that I should go to the ER. And I was shocked because I thought for sure they would just schedule me an appointment and I would go in and get reassured and move on with my life. I go to the ER and then I am taken into the non-stress test room with about 3 or 4 other moms. And I'm curtained off and I'm given a non-stress test. And during that non-stress test, Hank did not move. His heartbeat was found on the monitor, but it wasn't giving the escalations and de-escalations that they like to see. The nurse told me, we like to see baby's heart rate kind of going up and down. It's kind of staying the same for this hour that you've been sitting here. So we're going to send you down for an ultrasound. And mind you, I've been separated from my husband for over an hour. I'm concerned. I'm worried. I say, can I go outside really quick and see my husband? And the nurse says, I would rather you didn't. I would rather you actually come right back up. And I'm thinking, okay, she's being overdramatic. So I go into the ultrasound room and I'm given what I now know is a BPP, which is a biophysical profile. Now I know, because my subsequent pregnancies were high risk, that in a BPP, they must see significant movement that can indicate the baby's tone. They have to see a consistent heartbeat. They have to see the baby kind of practicing baby breathing movements, and they have to see a good amniotic fluid. And each of those things are given a score of 2. And if you get a perfect score, it's an 8 out of 8. So I sit there and I say, can I see my baby? And she kind of hesitates for a second, and then she goes, yeah, sure, here you go. And I go, oh, there he is. Okay. And I was like, how's he looking? Is he okay? And she goes, oh, he's probably just a sleepy baby. I get this all the time. You just have a sleepy, stubborn baby. And I remember thinking, well, my husband is sleepy and I am stubborn, so he's a mixture of both of us. And she then starts like jabbing my belly with the ultrasound wand, and she can't get him to move. So she has me start jumping up and down. She has me get up out of the bed and jump up and down to try to induce movements out of my baby. Now, when I told this story to a perinatologist when I was pregnant with my daughter a year later, her face really showed me that I had been mistreated, that this was malpractice, that this is not the way to perform a BPP. And everyone asks, whenever I tell this story, everyone asks, did you sue? You know, why didn't you sue? First of all, when your kid dies, you are not in a place to pursue a lawsuit. And there is a statute of limitations on these things. And I really think that needs to change, because by the time you're out of the fog of grief and you can actually think clearly, the statute of limitations is up. So that was one thing. We were also advised by an OB that a lot of times parents lose these cases because obstetrics is such a litigious form of medicine, discipline, I guess, that these hospitals have they have excellent lawyers. And there's not a lot of, it also comes down to sort of a he said, she said. In this case, she said, because it's not documented. There's no video of the ultrasound. It's just still images. So when I laid back down, she told me, oh, see, his foot was in one position, and then now it's in another position, so he obviously moved. And I regret this moment so much because I didn't trust my instincts. I didn't trust myself. I trusted this woman, and she gave me an 8 out of 8 score. And I went back up. I did go outside, give my husband a quick hug. And I think I said, I think everything's going to be okay. It sounds like he looks really good. And then I went back up, got put back on the monitor, and had a FaceTime call with my doctor that was cutting in and out. And basically, the message I received was, if anything changes, come back to the ER. I wake up the next morning and I realize he really has not moved. And I call the doctor's office again and I say, should I just go to the ER? What should I do? And she goes, no, here's how you properly do kick counts. And she's like horrified that I haven't been educated on this. So then I do the kick counts, and I don't even wait the full amount of time. I call it. I say, you know what? I'm just going. And so we go to the ER, and this time I'm scared. The first time, I thought I was going for reassurance. This time I'm scared. And there's a woman who's in active labor, and I hear her say, this is my 4th baby. My babies come fast. And in the waiting room, our husbands weren't allowed, our partners weren't allowed to be with us because of COVID. So we had to wait to be admitted for our partners to be let into the room, which was bad. She gets taken up, and they tell her that her husband has to go through a separate entrance. So I quickly text Drew, and I say, here's the entrance to go to for when it's time. I'm put into a wheelchair, put into an elevator, taken back to the L&D floor, and I notice that they wheel me directly into a room of my own and not into the non-stress test room. And I have a flicker of hope because I think that means I'm having a baby today. They put the monitor on me, and I think I'm overreacting. I've completely lost touch with my instincts, and I think that I'm the one who's overreacting and wasting these people's time. They put the monitor on me. They cannot find a heartbeat. They find a heartbeat, but it's mine. They tell me to wait a minute while they can get an ultrasound room, an ultrasound tech. I'm staring at the ceiling and I can't stop myself from sobbing. They bring in the ultrasound and immediately confirm that there's no heartbeat and that he's gone. And the only thing I wanted in that moment was just to not be alone. I wanted my husband there, and they give me my purse so I can call him. I say, just get up here. And he was in the elevator with the other dad. He comes into the room, and long story short, I decide to have a C-section because I can't bear the thought of being in labor for hours to deliver a dead baby, to lose all of my hope. And so at 11:30 that night, he was born, silent, and they wrapped him up and cleaned him up and took his footprints and his handprints and gave him a perfect little beanie that was knit by someone who I can only imagine has experienced a similar loss. And they hand me my perfect 4-pound, 1-ounce son who should have lived. He should have been born alive. And I have no doubt in my mind that had I had that C-section one day earlier, he would be. I would have a 5-year-old son. I would be looking at the end of kindergarten and be stressed out about him not ruining a Chromebook for first grade. Well, we can all take a breath of relief that the sad part is over. I'm sure that I will reference Hank's story throughout this podcast because there were systemic failures that led to his death. And there are systemic failures that lead to other issues within reproductive health care and within women's health. And I think that those things are very much connected, and we'll be exploring those things together. But now we can all just take a minute and say, okay, there it is. I will also say that next month I was plunged into the darkest grief I've ever experienced. I actually did have suicidal ideation and got into a really, really dark place a couple months after his death, which we might address that. We'll see if that comes up when we talk about mental health and postpartum and all of the delightful stuff that comes around with postpartum depression. Just a quick shout out to sertraline. Thank you, Zoloft, for saving my life. Probably wouldn't be here if it weren't for that drug. So shout out to sertraline. Okay, so let's just take a step back. And we're going to look at this story, and we are going to not be looking at it with the sad eyes. We're going to be looking at it with the analytical eyes. And we're going to be looking at what are the systemic issues that I can take away from this. Now, I get it. It's weird that I can look at the story of my son's death and be very analytical and be very cold. But that's just the way I'm wired, and I've done a lot of therapy. So the first thing I want to address is paternalism in medicine. And paternalism in medicine is the attitude that so many of us, whether you're a man or a woman, but especially women, have faced. And that is the attitude of, I'm the doctor, I know better, you're the pregnant person, you just trust me. There is also a mentality that by telling moms that stillbirth happens, that we are scaring moms and that we are fear-mongering. And to me, that ties in so much with this paternalistic attitude that doctors know better, the professionals know better, and that the parent is not the one who needs to be or deserves to be educated in this matter. The irony in that is that as soon as your child is born, you are hit with a barrage of information that is not categorized as scaring moms. It's categorized as empowerment. You are told the ABCs of sleep. You are taught how to keep your kid from drowning. You're taught about car seat safety. All of these things that are very important information to keeping your child alive. But it's packaged in a form of empowerment and education. It's not We don't think we're scaring moms when we tell them that car seat safety is important and that they should learn how to properly install a car seat. We don't think we're scaring moms when we tell them not to leave their kid in a bathtub. But for some reason, when we talk about kick counting, when we talk about side sleep, when we talk about the things that actually do prevent stillbirths, for some reason that is categorized as fear-mongering or scaring moms. And I think that is fascinating. I also just want to add, we're told not to eat lunch meat because it has a risk of listeria. Well, the risk of listeria is 1 in 25,000 pregnancies. It's still important. It's still worth educating about. But stillbirth is 1 in 175, and new studies are actually showing that it's even less rare. It's 1 in 150. So it's a lot more prevalent than issues like listeria or toxoplasms or these other things that we think are perfectly fine to educate mothers about. But for some reason, educating mothers about stillbirth is not acceptable. And I think this is a cultural issue. It's a systemic issue, but it's a cultural issue. And it's one that we have got to address. And so patient-centered care is the answer to this. It's looking at a patient, identifying seeing them as an individual who is capable of discernment and capable of decision making, and then giving autonomy to that person to be able to make decisions that are best for themselves and for their child. So we've got paternalism in medicine, we've got a lack of education, and we've got data collection. Okay, this is where I nerd out really hard, so y'all just need to stay with me. The Department of Health in California actually put out a 30-page report on the lack of data collection surrounding stillbirths. And I think this is in part because really annoying people such as myself had a couple of phone calls with the department in order to inform them that certain fetal death records never made it to vital statistics. For a while, I worked for Push for Empowered Pregnancy, and the head of the organization, her child's death was never recorded, just completely gone. And data collection is so important for public health measures. It is truly the first step. How can we know what interventions are necessary if we don't know who these stillbirths are happening to, why they are happening, and where the trigger points are for interventions? We can't know that without proper data. So 2 weeks after Hank died, I was told that I had had a placental abruption, that my placenta had separated from my uterus, and that is what caused his death. This didn't make sense to me because placental abruptions are abrupt, and my situation was more that Hank slowed down. Since, I noticed the change in movements 2 days before he died. So this didn't make any sense to me. Also, typically people who have placental abruptions experience a lot of bleeding. I didn't bleed that much, even after having the C-section. So a couple years after Hank dies, I actually spent $600 to investigate this and went to a doctor at Yale who looked at the microscopic slides of Hank's placenta and his cord, and was able to conclude that Hank died because he had cord compressions. Now, first of all, I don't think placental abruption ever made it to Hank's fetal death record, because these fetal death records are filled out by typically hospital staff or funeral director staff, and there is no connection point after the information is found by the pathologist, communicated by the OB, and then put onto the death record. The death records are filled out typically by someone at the hospital when the event happens, and they are unamendable. So even if I find out my son's true cause of death 2 years later or 2 weeks later, I can't go back and amend it for the record. So that information doesn't get to the CDC, and it doesn't get to the NIH, and it doesn't get to these agencies that are responsible for finding out who these stillbirths are occurring to and why they are occurring. So that's a huge systemic failure that a lot of people are working on trying to get fixed. And I really think that the answer is creating a model at the state level that can then be replicated throughout the country. California is starting to work on this. Like I said, they put out that 30-page report that really emphasized that people need to be trained on how to properly fill out these forms. And actually, a good friend of mine is working on a bill in North Carolina that will make these forms amendable. So, exciting stuff. Huge opportunity for change. Thank you for nerding out with me. Okay, one of the most horrific parts of Hank's death was hours after he had died, while he was still in our room with us at like 5 a.m, a man came into our room and introduced himself as a social worker. He was on the younger side. Like, I remember thinking like, okay, he's like my age or younger. I was in my 20s. And he then kind of rushed through this description of an autopsy that I will not repeat on this podcast. It terrified us. And we can go to Conspiracy Town and think about maybe why hospitals wouldn't want a parent to investigate the cause of their child's death. But I think I can go there. I can go to the Conspiracy Town. I can also just take a step back and say, like, maybe this guy was just bad at his job. I will say I've heard this from multiple parents, that they have had autopsy presented to them as just really graphically. And then also something that I've heard from multiple parents, and including myself, was that it was presented that we most likely won't be able to find a cause from an autopsy. That is not true. I don't know what the statistics are, but statistically, you are more likely to find a cause if you do an autopsy. And there's actually different types of autopsies you can do. There's a lot of options here, and that information is not being presented well to parents at all. And there was a huge effort to kind of educate hospital staff on this and provide pamphlets and booklets for both hospital staff and parents in order to properly educate them on making an informed decision about autopsy. We decided not to have an autopsy. I have mixed feelings about that. I feel much better that we do now know the true cause of Hank's death. And I think that I'm bummed it took so long to get there, but I'm glad we got there. Another systemic failure is just the standard of care. I'll talk about this a little bit more when I talk about Max's pregnancy, but the placentas and cords need more monitoring. We have to figure out ways to monitor the placenta and the cord in utero to identify when blood is not flowing to the baby. And there is a great organization called Measure the Placenta, which I'm sure I will feature on this podcast at some point in time, that is leading a nationwide effort to begin measuring placentas as a standard of care, because a lot of times if the placenta is too small or too big, but typically too small, it just runs out of juice. It's not able to sustain a baby, especially if that baby is on the bigger side near the end of pregnancy. So we zoomed in to one story, which was my story. We zoomed out. We looked at the systemic failures that led to Hank's death or contributed to just an overall bad situation for stillbirths in the United States. And now I would love to share with you the birth of my beautiful daughter, Tavy. So Tavy is Octavia Victory Felker. I loved giving her the name Victory because her being born alive felt like a victory for us all. It felt like we had made it through pregnancy and we made it through the systems that surround maternity in America. With Tavy's pregnancy, nothing was similar to Hank's. I felt no sense of urgency to protect Hank, and I felt an extreme sense of urgency to protect Tavy. I mean, it was like a night and day difference, the level of care and attention I received. Anytime I said, hey, I'm not feeling her move, or hey, I'm scared, come in right now. Come on in. Like, if the ultrasound place is closed, come into the hospital. And we ended up having her early. She was born at 36 weeks and 5 days because my uterus was being funky and it was doing what I guess is called irritable uterus, which I swear my uterus has been irritable its whole life. But it was hard as a basketball. So the only difference between Tavy's pregnancy medically was that A, she lived, and B, I had thrombocytopenia, which is a decrease in platelets. One of the other reasons why I eventually decided to have my tubes tied is that every time I'm pregnant, my body decides to kill off all the platelets in my blood. And they don't think this is related to Hank's death at all, but it was just one more fun thing to deal with. I was on steroids and got multiple blood draws near the end of pregnancy just to make sure that I had enough platelets in there to make it through a C-section. Halfway through Tavy's pregnancy, I had a panic attack at an OB appointment. I was very stressed because, I had been told, we're really going to focus on fetal movement, and I had an anterior placenta. So I could not feel her the same way that I could feel Hank. And that was really stressful. So the placenta was in the front instead of in the back. And I was in a room waiting for my midwife to come in. I hadn't met her before. And I was not doing good. And as soon as she walked through the door, I just started bawling. And she's like, oh my gosh, are you okay? Like, what's going on? Tell me what's happening. And I told her everything. And she just gave me a hug and she was like, hey, you are going to be our first line of defense, but you are not alone in this. We are here with you, we are working with you, and we are going to keep your baby alive. You're going to be okay. And I was just like, okay. It was very helpful and very reassuring. And, if anybody out there is in L&D or is in prenatal care, hug your patients. They need a shoulder to cry on sometimes, and they need the reassurance that you're going to do everything in your power to make sure that they have a healthy pregnancy. I'm 36 weeks and 5 days. My uterus is not doing well, and we decide we're go for C-section now. And I'm like, luckily I brought my bag because just in case. And I'm like, all right, we'll go for lunch. Let's do this. Drew took a picture of me. I'll see if I can upload it, where I'm just trying to get in the zone of I'm about to be cut open, and I'm signing all the papers, doing all the things, getting the IVs, getting strapped up, all this stuff. Next thing I know, I'm wheeled out. Mind you, I've already had a C-section, and because of the trauma surrounding that C-section, I don't have a really good memory of how things went, but I remember not feeling anything, which is a pretty good goal to have with a C-section. C-section's happening, Tavy's out. She doesn't cry immediately because she just needed to start her first moments freaking us out. And then she finally starts crying. She's good. I was fully prepared for a NICU stay or a NICU, moment because she was so early. They were like, this kid is huge. And her lungs worked. She was here and she was ready, and she's amazing. She's just a wonderful person. I love her so much. So she's here and we're okay. And as they're cleaning her up, I'm starting to notice that I'm not just feeling pressure, I'm feeling pain. I think she was only on my chest for 30 seconds to a minute because I was grimacing in a ton of pain. And I turned to my anesthesiologist and I said, hey, I'm feeling this. And she was like, no, honey, if you could feel this, you would be screaming. Now, here's the thing. I don't know how anesthesia works, okay? I'm not an anesthesiologist. I'm never going to be an anesthesiologist. I'm not a clinician. I'm never going to be a clinician. But I know what I felt in that moment. And I wasn't feeling where the incision was, which is below the bikini line. It's fairly low. I was feeling around and above my belly button. So yeah, I didn't feel the extreme pain of a incision, but I did, like, it's not that far. And I did feel the pain of my literal organs being moved around and put back together in order to sew me up and to have a normal body. At one point, I turned to Drew and I was like, there is a doctor's arm inside my body. Like, that is, I could feel that. And so I turned to my anesthesiologist and I'm like, I'm in pain. And she was like, no, honey, no, honey. If you could feel this, you'd be screaming. And what I nearly said was, bitch, buckle up, because I'm going to start screaming. And instead of screaming, I kind of groaned and grimaced, and it was enough for her to go, uh-oh, maybe she is actually feeling this. And the next thing I know, I hear so many cc's of ketamine, and I go bye-bye. So the first 10 minutes of my daughter's life were not my favorite 10 minutes of mine. And I had a little ketamine high, went down the K-hole, come out of it. I'm still in a lot of pain, got fentanyl, and then we got back on track. But later in this podcast, we're going to be talking about women's pain and how women's pain is handled in medical settings. And there is a fantastic documentary podcast called The Retrievals. I blanked on it for a second. And that also takes a fascinating look into women's pain. And while I was listening to that podcast, I was having literal flashbacks to Tavy's birth. It is so important that we take women's pain seriously. And anybody's pain, not just women. But it is very true that women's pain gets diminished and excused in medical settings. And we're done. We're all done. Okay. Final baby, Maximus Valor Felker. I know we're extra with the names, but Maximus, Maxie is our sweet little boy. He really is a sweet little boy. He's also wild, but he's very sweet. So I become pregnant with Max way faster than I expected. Our kids are 19 months apart. And I'm like, here we go. I'm pregnant. I'm scared. I'm gearing myself up for another 8 months of hell. And I have this like feeling in the back of my head where I can't stop thinking about Tavy's cord. So we've got all these pictures from Tavy's C-section, which are, I love showing them to people to like freak them out. But anyway, so we've got pictures of Tavy's C-section, and as they're lifting her out, her cord looks weird. And I'm not a cord expert. I don't know anything about cords, but I've seen pictures of babies' cords, and I've seen these things online, and I'm like, that doesn't look normal. So through my work with Push Pregnancy, I get connected to someone who is a cord expert. This is his life. And I send him the picture, and I say, hey, would you mind taking a look at this cord and letting me know is this weird? Am I crazy? What's going on? And I'm fully expecting him to email me back and say, like, you're okay, you're just pregnant after loss and seeing things that aren't there. No, this man emails me back and he says, this is a textbook example of torsion, which is hypercoiling. It's when the cord, something happens where the baby either moves around a lot while they're real little. They don't really know why it happens, but sometimes cords get hypercoiled. And a hypercoiled cord does not mean that the baby is going to die. Plenty of babies are born living with hypercoiled cords. But me being analytical and me wanting all of the information at my disposal, I start to think, okay, I'm 2 for 2 on bad cords. We don't know if Hank's cord was hypercoiled or not, but we do know that he had cord compressions and that led to his death. Tavy's born with a hypercoiled cord. Her movements didn't really slow down and she wasn't experiencing distress, but she was also born early, so we don't know what would happen if I had gone to full term. So I'm just keeping all this data in my mind, and I'm pregnant. And I get the news that Tavy had a hypercoiled cord while Drew's out of town, and I don't have my person to process. And I'm trying to navigate this. And I finally say, I'm going to treat myself to a McDonald's ice cream and French fries. And I'm in the line, and Drew calls me, and I lose it. And I'm like, I'm freaking the fuck out. I do not know what I'm going to do. And he's like, we're going to handle this. We're going to ask them to look at the cord. We're going to figure this out. We actually ended up having a phone call with the cord expert who said, listen, like, you need to ask them to do a Doppler scan on the cord. Those were his words, Doppler scan on the cord. And I'm vaguely familiar with what a Doppler scan is right now, okay? So I go into my 20-week appointment, the anatomy scan, and I see the MFM that I had for Tavy's entire pregnancy. I loved this MFM. She was so reassuring. She was super helpful. I was so excited to see her again. So I go through the whole anatomy scan, and she comes in afterwards, and she's like, everything looks great, blah, blah, blah. And I say, hey, so I have this report from a doctor at Yale. This report shows that, Hank died from cord compressions. And then I have this email from this doctor, who says that Tavy had hypercoiling in her cord. Could we please look at this baby's cord and do a Doppler scan when we do our regular ultrasounds? I'm on a high-risk schedule, so I'm going to be getting ultrasounds. At some point, I'm going to be getting ultrasounds once a week. So can you switch on the Doppler and show me the cord? And she goes, nope, that's not standard of care. Nope. We only look at the cord if the baby's measuring small. Okay, well, my daughter was born at 36 weeks at 8 pounds, 15 ounces. So I think it's safe to say that I make big babies. Even Hank, who died, was a big baby. Drew's tall. I'm fairly tall. We make big babies. Hank was measuring exactly the size that he should be measuring, and then he died. Size and growth was not an indicator of whether or not he was getting the nutrients he needed through his cord. So I understand that the standard of care is that if babies are measuring small, we look at the cord. But that is not an adequate indicator for me as an individual. And this is why individualized care is so important, because sometimes it means going above the standard to prevent someone from mentally spiraling or their baby dying. Those are really important reasons why it's okay to just switch on the Doppler and give this mom a little reassurance. And she looks at me and she says, I'm not going to do it, and you're not going to find anyone else who will. And that was when I said, watch me. I didn't say that out loud. I don't have the guts to say stuff like that out loud. But in my head, I was like, watch me. I think within a week, I had completely switched. I had scheduled an appointment with UCSF. A couple weeks after that, I went to the appointment with UCSF and had an anatomy scan. And in that anatomy scan, after it was all said and done, I said, hey, we've had a history of cord issues. Is there any way that you can do a Doppler scan on the cord and look for hypercoiling? And this woman said, oh, yeah, no problem. 1 minute. Re-jellies me up. I mean, I argued with that MFM for 10 minutes over something that took maybe 2 minutes. And when I tell people that, they're just astonished. But when you've been working in this world and you've heard all these stories, it's not shocking to me, because the system is not set up for individualized care. And I don't think that, and I don't say that to excuse this doctor and say that, she was just doing, like, we have lived in this system where these doctors only have a certain amount of time with each person. They're covering their ass, and they are adhering to whatever the bare minimum of the standard is, because it's when they go outside of the standard that there's the risk. And it needs to change. We need to see people seeing patients as individuals and recognizing that their histories may be different, or that they may be at higher risks because of who they are. They may be at a higher risk because statistically institutionalized racism has led them to have worse outcomes. They may be at a higher risk because these societal determinants of health, these social determinants of health, put them at a place where they are more likely to have adverse maternal health outcomes. And so we need to stop looking at these people as numbers and looking at these patients as individuals and realizing the risks and the benefits of treating individuals. Okay, so I end up switching my care completely to UCSF. It was great. I had the best care that I'd received in all 3 pregnancies. 37 weeks, I have Max. He is healthy and loud, and everything is great. And then I have the best birth out of all 3, planned 37-week C-section. I have a conversation with the anesthesiologist beforehand where I explain that I felt a lot of my daughter's C-section. And at first he kind of doubts me, but then he goes and looks at my chart and comes back and says, yeah, so for some reason you were not given the full dose of anesthesia with your daughter's birth. We are definitely giving you the full dose of anesthesia today. Great. So, sounds like a plan. And so Max is born. I don't feel anything. And I got my tubes removed because the idea of being pregnant again filled me with so much dread. And I'll never forget the feeling of having Max on my chest and being in this room. There was a rainstorm happening. There's rain just like pounding on the window. And I feel so at peace because I know I'm done. I never have to do it again. Okay, so taking all of this into consideration and zooming out, we see that we need to have a national sense of urgency when it comes to stillbirth and maternal health outcomes. We need to improve the standard of care and seek individualized care whenever possible. And we need to improve data collection. We need to be able to monitor who these adverse maternal health outcomes are happening to and why they are happening, and contribute to a body of research that can be, or a body of evidence that can be researched and utilized to prevent these things from happening. We can address this culture of paternalism that is so rampant in medicine, and we can also invest in awareness campaigns that educate parents on fetal movement monitoring in order for them to be the first line of defense to know when their baby is in distress. I also want to take a step back and recognize that stillbirth happens to Black and Indigenous women at 3 times the rate of white women. And that is mainly incredibly due to systemic racism. And so that is something that we will definitely be talking about in this podcast. We're going to do a whole episode on Black maternal health, which I'm very, very excited about. Okay, zooming in, what are some things that you can do for someone who's pregnant, or maybe yourself if you ever become pregnant? First, you can download the Count the Kicks app. If you're pregnant, this is an incredible tool to help you monitor your baby's movements. You can also follow Count the Kicks online, share their information, share their posts, and also just help people be more aware of baby's movements. The number one thing that all of us can do is we can stop spreading the lie that babies slow down at the end of pregnancy. This is misinformation that I've heard from so many moms that was kind of in the back of their head while they were discounting their own instincts, telling them that something was wrong. So do not believe that. Do not share it. Let's just no more of the babies slow down at the end of pregnancy. Okay. The other thing I want you to know is that you can change your provider at any time. Both in Tavi's pregnancy and in Max's pregnancy, I completely switched providers. And I want to recognize that this is not available to every person. And I'm so sorry if you live in a maternal health desert or if this isn't available to you. But please, if you are not feeling supported and if you are not in a space where you feel like you're getting the care that you need and deserve, try to change providers, or at the very least, hire a doula. Actually, everyone should try to hire a doula anyway. I want you to know that you can go to the ER at any point in time in your pregnancy, and you can go to any ER. If you are pregnant and you go to an ER, you have to be seen. That is the rules. And so you have that right and you have that ability to, if things feel off, if you're not feeling good, you get yourself to the ER. And finally, I want you to trust your instincts. There is a crazy level of instinct that comes with being a mom. And that doesn't start the day your baby's born. That starts the day that you accept motherhood, the day that you realize that you are pregnant and you are bringing a child into this world and that you are going to be a mom. So trust those mother instincts because they rarely lead you astray. Alrighty. Well, thank you everyone so much for joining me for this episode. We've got a lot of great topics ahead. We're going to be talking about purity culture, Black maternal health, women's pain, ADHD, PMDD. We're going to be talking about perimenopause. We'll be talking about birth control. We're going to be talking about so many things that are related to women's health and maternal health. And I'm really excited to learn with you. And we've got a great lineup of experts who are going to be sharing this with us as well. Well, thank you all for joining, and I hope you have a beautiful and a healthy day.